Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Today it's my pleasure to be the moderator of this ground round. This today ground round will be presented by Dr. Azza Maktabi. Our esteemed speaker today, Dr. Azza Maktabi, she's Saudi board certified, and after that she had two prestigious fellowships. One in ocular oncology, and it was with the Shields Group in the United States, and the other one was with Dr. Ralph Eagle in ocular pathology at Wolds Eye Hospital. Dr. Maktabi joined KKH in 2013, where she worked as ocular pathologist, and also with Dr. Saleh Al-Misfar, who's leading the retinoblastoma treatment in the kingdom. Her special interest in retinoblastoma and also in ocular pathology and research. So she's a well-known figure nationally and internationally. She has more than 90 publications in the PubMed listed journals. Today, ground round was supposed to be presented by a visiting professor, but unfortunately he couldn't come, so Dr. Azza gladly accepted to present this ground round. She will share with us an insight about a rare tumor. So what is this rare tumor? We'll find out, and we will learn more about this tumor. Please join me to welcome Dr. Azza Maktabi.
Thank you, Dr. Abdullah, for your kind welcoming. First, I would like to apologize about the quality of my voice. I hope people will not run away. So I tried to make it interesting and short because we have the medical staff meeting. So I will start with a quiz about like case scenarios. First case is a 5-year-old boy presented with lens notch, and there's no history of trauma. So the diagnosis is lens coloboma, medulloepithelioma, and trauma. Can I see hands, please? 1, 2, 3. Imagine the notch. Okay, so 2 medulloepithelioma, 2, 3 hands, and trauma. Okay. Next is a 9-year-old presented with anterior chamber floating cyst. And these are the differential diagnosis or the working diagnosis: toxocariasis, floating cyst, or medulloepithelioma. Dr. Sausan, what do you say? Just thinking. Okay. 4-year-old presented with uveitis, presented with cyclitic membrane, and working diagnosis is uveitis, number 1, persistent fetus vasculature, I think, or medulloepithelioma. Thank you. So one more. One more. So 2-year-old, but I changed the age because of now younger age, you think of RB actually, and this is presented with new vascular glaucoma. So again, medulloepithelioma, ROP or RB. So people are awake and they notice that the common diagnosis among all these is medulloepithelioma. And yes, I'm going to talk about medulloepithelioma. Why it is a hidden tumor? Because it's rare. Maybe people with long expertise in ocular oncology might see one case in their experience. The hidden location, the anatomic location, it's hidden behind the iris, and it's slowly growing. So maybe reports, they said around 5 years interval between the signs and symptoms and the diagnosis, and people reported up to 10 years. And usually they present it with secondary manifestation like secondary cataract, secondary glaucoma. So it takes really a long time until people think about medulloepithelioma. And this is the main purpose of this lecture. Keep it in your mind and think about it. When I did research, I find only 140. Actually, they were around 170 when I use the filter of human, it comes to 140. And I did not look through all of them. Probably it will be less. So a little bit about the history. It was first described in 1892 by Badal and Langley and as a carcinoma primitive. Then Verhoeven, who is a renowned pathologist in 1904, described it in detail, but he called it teratoneuroma. And only Fuchs, he called it dictyoma because of the picture, as you can see here, the net-like appearance. And only in 1931, Grinkel provided the tumor the term medullobethelioma. It's originated from medullary epithelium or inner layer of the optic cup. And if we look at the classification, which was initiated initially by Zimmerman, and this is the modified by the Shields, it is a congenital, and we can see that it is either non-teratoid or teratoid, and both of them can be subclassified into benign and malignant. So it's uncommon, though it's rare and uncommon, still it is the second common intraocular tumor malignancy in children. Usually it's unilateral, sporadic, it's congenital, non-hereditary, and male and females are equally affected. Usually they are diagnosed at the first decade of life. However, reported cases in adult is there, and usually lots of theories about that adulthood involvement is because of, again, the late onset of diagnosis. So people postulated that it is there hidden and as a benign version, then when it starts to transform into malignancy, then it appeared at the childhood. Lots of list of symptoms and signs that patient might present with, and this is make the diagnosis even difficult. Small lesion may went unnoticed and asymptomatic. Lots of people, patient present with loss of vision, leukocoria, and the list is long. Now you have some pictures of the lens notch from the Shields on your left hand, and this is from Dr. Musfer collection from KKH with the cyclitic membrane. So actually, I'm going to discuss thoroughly this study, which is recently published in 2024, about one case and literature review. So this is the recent, largest review. So this was cases were searched in PubMed until May 23, and our inclusion criteria, only those who have definite cytological or histological diagnosis. There are some other series that they include adults. We are including only children below 18 years of age. So here we are, other studies include adult, and they include presumed medulloepithelioma. So we studied for each publication the authors, the year of publication, the number of reported cases, the demographic, clinical presentation, definite diagnosis, and the classification. Of course, we looked at the imaging and modalities of treatment and the outcomes. So we found 65 studies, 97 children, including ours, make it a total of 98 patients. And the age were newborn. Patient one case presented as a newborn, neonate case, and the elder is 17 with a median age of 5 years, and the mean age as well is around 5 years of here. Again, there's no significant gender predilection, and the male to female ratio is 1 to 1.5. So this is what I mentioned earlier, that the symptoms, the interval might be 5 years, and for malignant, they are even longer, up to 11 years. And it's not 100% unilateral. 2 cases were reported as bilateral. So this is also very important to know. So signs and symptoms, like almost 1/3, they present with reduced visual acuity, glaucoma symptoms for glaucoma people, leukocoria, and cataract. That's why it's in the differential diagnosis of retinoblastoma, mass in the pupil or in the anterior chamber, new vessels or iris, new vascularization, ophthalmos, and proptosis, and more is the list. So a floating cyst in the anterior chamber or in behind the cornea, over the iris, on the lens, vitreous cavity, anywhere. And they might present with anterior uveitis, erosion of the iris root, retrolental neoplastic cyclitic membrane, even cellulitis and endophthalmitis. And that's why it's very masquerading as a cataract, glaucoma, uveitis, and 20% of those patients that we reviewed had previous surgery as in form of lensectomy, glaucoma surgery. And 75% of those cases presented with secondary glaucoma of different etiology. So local extension to other adjacent intraocular structure occurs in different tissue, like in iris 11%, retina 5%, and so on. What about the metastasis? One case only metastasized to the submandibular nodes, and 2 to the parotid gland, and 1 distal metastasis to the brain. And there's a correlation between the D1, DICER1 gene with some systemic association with the pleuropulmonary blastoma. So what we need for the diagnosis, fluorescein angiography is helpful, and it shows hyperfluorescence early and then late staining, and this is from the Shields collection. You can see the leakage. And then other imaging tools also help very well in diagnosis and important in the management. So an anterior segment OCT, it will delineate the size and the extent of the ciliary body mass. And very important, which is very unique and characteristic for medulloepithelioma, is the presence of the cyst. And it also might detect the floating cyst or the cyclitic membrane. You can see here, this is from our collection. You can see the heterogeneity. You can see the different acousty, and there's some calcification, and very important, the cyst. The MRI also again will reveal a heterogeneous mass with these cystic components, and it is isotense to mildly hypertense on T1. Histology, 4% of those patients underwent FNA, and that confirmed the diagnosis, and 4% they did a biopsy, and most of the rest are diagnosed after inoculation. In regards to the subclassification, surprisingly, 70% of those cases were malignant, either teratoid or non-teratoid. So what is non-teratoid? By histo, they composed of clusters of proliferating, poorly differentiated neuroepithelial cells. Looks like retinoblastoma. However, even forming rosettes. However, the rosettes are larger and multi-layer. And the cysts are very obvious by histopathology, and there's frequent primitive tubules with empty clefts, and these are surrounded by mesenchymal tissue that is rich in hyaluronic acid, which is highlighted by special stains that we are going to look at soon. So this is how it looks. It looks in cords. And it's a blue cell tumor, by the way. That's why you see the blue colors. And these are the cysts, and this is the primitive or rosette-like appearance. And on the right side, you can see the Alcian blue stain staining the hyaluronic acid with blue. And this is, I just finished talking about the non-teratoid. So when it is teratoid, when you have extra structures like heteroplastic elements like cartilage in this case. So what is the criteria for malignancy? This is very important slide. So it's not always a distinct, it's not white and black. It's there's a gray zone, and it's very difficult to identify those cases who are malignant. And I'm talking about histology. Recurrent medullobethelioma tends to have more malignant histopathological features, and of course aggressiveness of the tumor, like invasion and to near structures, is also give you a clue that this is probably has a malignant tendency. In regards to histopathology, when we say that it is malignant, when we have a poorly differentiated neuroplastic cells, and when we have a sarcomatous area, necrosis, mitosis, of course, this is very important, and when there is adjacent structure invasion or even extraocular extension. So what is the management? In this study, 9% they did iridectomy, but all of them, enucleation was done later on, 72 enucleation brachytherapy in 14 patients. And systemic chemotherapy with or without radiation were used in 15% of the cases. Exoneration when there is orbital extension is recommended. Only one case from this study underwent intraocular chemotherapy by Francis Munir, our remote guest that he visited us at KKH. And I'm going to discuss this paper because it's the only one, and nobody tried, at least not in the literature. So this child was presented at 17 months of old, and he was diagnosed with ciliary body medullobethelioma, but the parents resist the idea of enucleation, and they asked the advice of Francis Munir, and he advised to do intracameral and intravitreal in concomitant melphalan, and patient received 3 injections, and according to this paper, that patient has developed developed glaucoma, and he had underwent multiple glaucoma surgery, cataract surgery, 7 intravitreal anti-VEGF. This is, we cannot claim this is because of the disease itself or because of the medication. So, but he claimed that after 5 years of follow-up, he was doing fine with trabeculectomy and 4 glaucoma medication, topical. But this is convenient for the parents. And his vision, best corrected vision, was 20/25. So what's the prognosis of medullobethelioma? If the tumor is confined to the globe, obviously this is a very good prognosis, and they postulated that the 5-year survival is up to 90 to 95% after enucleation. When there's a metastasis, of course, will decrease, and but this is fortunately is uncommon. Extension of the tumor to the extrascleral orbital soft tissue, of course, dramatically decrease the rate of increase the rate of metastasis and the recurrence. So I'm going to discuss 3 cases from the KKH patients that they were managed by Dr. Saleh Al-Misfir. And the first case is the one published with the study I just discussed. So this is a 6-year-old male presented with a painless bulging mass in the inferotemporal quadrant of the left eye for more than 1 year. So he has a long history that I would like to take you through, because it's very important. So his first visit to our hospital was when he was 1 year and 8 months of old. At that time, he was referred to us as an acute endophthalmitis for treatment. And he had, prior to that, history of cataract surgery at age of 6 months, followed by filtering Ahmed implant at age of 1 year. Then he developed organized dense vitreous hemorrhage and intense inflammation. And then he was diagnosed with suspicious of endophthalmitis. He had pars plana vitrectomy and intravitreal antibiotics injection. Then he was referred to us. At that time, his vision was 20/25, and the left eye is unremarkable. This is what we saw on presentation, a bulging mass, very thin cornea, thin sclera as well. Vision is no light perception, and with this huge mass at the limbus. Of course, the fundus was not visible. The B scan showed heterogeneous, dense vitreous opacity with large, highly reflective lesion causing shadowing and 360-degree retinal detachment. The UBM indicate an pherotemporal elevated area with dense organized opacity. The MRI confirmed the presence of heterogeneous soft tissue and confirmed the scleral and extrascleral extension. And you can see here the imaging. And this is the pathology. You can see this is representing the huge mass which was seen anteriorly. This is anterior staphyloma that is filled with the tumor. And this is on the left side, you can see the typical cords, but they are not benign looking cords. They are malignant with some mitosis. And in the middle photos, you can see here, this is the pigmented layer is the RPE, and you can see even the choroid were invaded. And you can see the cartilage indicating that this is a teratoid malignant meduloepithelioma. Patient referred for King Faisal and the Research Center for 6 cycles of systemic chemotherapy, and he was doing fine after 24 months with no evidence of recurrence or distant metastasis. The second case is a 8-year-old Saudi boy. He presented with us with simple history of squeezing at school. And actually, he is 8-year-old, and only the teacher noticed that he is not seeing well. And he was seen initially at National Guard Hospital and referred to Dr. Saleh Al-Musfir as a ciliary body mass with retinal detachment in March 2023. So on examination, he was almost no light perception. We tried ourselves, and in the left eye was fine, and no left eye was unremarkable. Pressure was fine. And then the conjunctiva was quiet, the cornea was clear, but the AC was shallow, and there's an ectropion UV, and there is a patchy iris atrophy, MVI, and this cyclitic membrane. So you can see here on your left side the external appearance of his eye, and on the left eye the retrolental cyclitic membrane, which have some vascularization. And the ultrasound of the B scan shows total RD, and UBM beautifully showed the heterogeneity with the cystic formation. That is very important and crucial for the diagnosis. And MRI also shows this heterogeneity, and though the child did not stay still and it was difficult, but again, it was suggestive of meduloepithelioma. So what's the management? The patient went back and forth. We have international and national consultation. They got the consultation from Greenwood ophthalmologist, ocular oncologist, and we offered them either observation, since it has been for a long time and nothing much change, even not noticed by the parents, or to inoculate since it has some malignant potential. And they were hesitant to inoculate the eye. So we looked again at the literature, and we found that some people in China, they treated cases with intra-arterial chemotherapy with melphalan. And since we have this established between us and King Faisal Specialist Hospital for retinoblastoma, so we offered them this solution, and they agreed, and he received 5 cycles of intra-arterial chemo melphalan. Actually, there's no much changed in his clinical appearance, and was seen in July 24. The only thing I noticed when I reviewed his file, maybe Dr. Saleh, he could confirm this, that the vision improved. He was no light perception for many times, that me and Dr. Saleh checked ourselves. And then now I found in his recent records that it is query light perception. And at one stage, it was even 2200. So that's a very good improvement to the parents, actually. The last case, which is a very nice case, is a 5-year-old girl presented to KKH recently in July 2014 with an iris mass. And she is no light perception in the left eye and the right eye again. And I'm putting 2 question mark, exclamation mark, because this could be missed. Even parents, they don't know that their child is blind with one eye. And the pressure was high. It was 43. Slit lamp examination. The cornea, the conj was quiet and the cornea is clear. The AC is deep, but there was some mixed cells there, and the lens was clear. Iris shows ectropion UV with posterior synechiae, and there is Robusus iridis, and there is an elevated red yellowish mass in the iris temporally. And the left eye was unremarkable. And this is how it looks clinically. This is the mass here, you can see it. And I think, if you agree with me, I did not examine the patient, look like, this is the synechia, of course, and they look like there's a sector cataract. And beautifully, the UBM shows the heterogeneity of this tumor with the cystic changes. And Dr. Saleh Al-Misfer, he did a very great job as usual and sent me a biopsy, which was very helpful. And if you remember the previous pathology, you can see that they have the similar cores and the cores of these neuroplastic cells. And with the Alshem blue, we confirmed the presence of hyaluronic acid. And on the small photos on the top, you can see the cyst as well. So this is just to tell you, if you give the pathologist a good sample, they can give you a good answer. So in conclusion, medullobethelioma is often misdiagnosed, causing delay in the treatment. Final diagnosis is achieved through histopathology, and excellent prognosis in cases with no extra scleral extension. And we presented the different spectrum of presentation. So keep alert when you have this unsolved symptoms like glaucoma, cataract in children, and you don't know what's going on. So early suspicion is very important. And for those who did not have the chance to look at the grossing, this is one of the fabulous photos. Subhanallah, I like to look at it. This is from the back of the lens, and you can see the ciliary processes, the pars plicata and the pars plana. Thank you.
Thank you, Dr. Azza, for really nice presentation. I will open the floor now for discussion or any comments or questions.
I'd like to hear from Dr. Saleh about
how many medullobethelioma cases in our registry?
Well, I tried to get this answer only today I got, but I think we have 7 cases from 2000, because this is what we have. We can retrieve electronically. Otherwise, we need to go manually or by the
Because
assay.
I remember one child presented with tear chamber seeding and blind eye, and we nucleated him, and it was not included in your presentation. I think there is some picture for him.
I did not go through all the cases. Okay. I just threw 3 cases. One is with the publication and the 2 recent one, but I did not present all the cases. Actually, unfortunately, there's one case in this list that it was eviscerated, not even enucleated, and after evisceration, it was found to be malignant teratoid medullobethelioma.
I think the last case, we did a fluorescein angiography, and Dr. Hassan Dibi with us, I think, and Dr. Suleiman. Yes. And there was no perfusion, most of the retina. He just, this is the child with secondary glaucoma, and he developed cataract maybe not at the time of the fluorescein angiography. And we discussed the case, me and Abdullah, with the family for possible enucleation. They're from Mecca, but I didn't know when we are.
They asked for a medical report for second opinion, and they are not yet back. They just came recently in November, actually.
Thank you.
Welcome. I would like to hear from you, Dr. Saleh, about the intraarterial with medullobethelioma with Sattam.
This is for Sattam.
Yes.
The second case. Sattam is almost 8 to 9 years old, presented to us. His family were told by the teacher that his vision maybe is not good. And we consulted the retina, and we looked at the patient. We did all the MRI and the UPM ultrasound. And we find that the child sometimes he has vision, he has shallow RB. And after we review the literature, we decided to give him some intraarterial chemotherapy. And we decided to ask the super selective chemotherapy team at King Faisal Specialist Hospital to give it to the ophthalmic artery rather than to give it to the central retinal artery, because we think this will give the anterior ciliary artery more supply and supply the ciliary body. The child doing fine, he's stable, not progressing to any serious finding. We're still planning to add him maybe to Dr. Mora to do buckle to see if the retina could be attached. If we observe him for some time and there's no changes, we may consider the cataract surgery.
Thank you.
Dr. Said.
Thank you very much, Dr. for excellent informative lecture about the very rare disease. I have two questions, one for you and one for Dr. Masfer. First, inoculation is too high, 72. Is it because of the late presentation or misdiagnosis, or the disease is not responding to treatment? The second question to Dr. Masfer, are you doing total excision or just only take sample? Because sometimes it might be cyst or it might be severely blood vessels and to lead to severe bleeding. So how do you manage this, Dr. Masfer?
Thank you, Dr. Said. We are making the diagnosis based on maybe 3 points. First, our clinical impression, MRI, and at the same time we'll do UPM. And based on the UPM and if there is cystic, it's most probably it is the medulla epithelioma. Such cases are very rare. Experience even at the international level is very limited. I mean, there is no much experience and there is no appropriate management for such cases. I mean, everybody will try to do his best to cure the child. If the eye is in bad shape, they will enucleate the eyes. Resection, the resection rate, recurrence after resection is about 50 to 60%. We are not doing resection, are doing either now we are trying chemotherapy, and cases with poor outcome, we do enucleation.
Thank you, Dr. Saleh. In regard to your first question, Dr. Said, I did not, and I'm not aware that we have a full study about the medulla epithelioma at KKH. But some of our references is individual reports from Dr. At-Turbaq, Dr. Al-Amri, and Dr. Kattan. There's one study by Dr. Deepak in collaboration with Eberhardt about genetics, microRNA. So the 70% is from the total review of the studies in the literature, which is 98 patients. It's not ours inoculation rate. However, we are expecting that this will be the same because, as I mentioned, 70% of them are tend to be by histo after inoculation a malignant teratoid, malignant medulla epithelioma. If this answers his question, Dr. Qattan.
When we reviewed the cases of medulloepithelioma a long time ago when I was here at King Khalid Eye Hospital, some of the enucleated globes were actually enucleated because of end-stage glaucoma as ophthalmic globes, and the medulloepithelioma was not diagnosed until after the enucleation. And luckily enough, most of these cases were actually benign medulloepithelioma because if they were malignant, they would have behaved in a different way and they would have been picked up because of extraocular extension, for example. And there was one interesting case that was presented by Dr. Deepak in one of the ophthalmic pathology meetings of an example of medulloepithelioma, the relatively advanced. The parents were offered enucleation. They disappeared for like 2 years in a row, and it came back with extensive extraocular extension. It was eating up the whole cornea, extending to the outside externally, and ended up, of course, by enucleation. And this one turned out to be malignant. You would expect so.
Yeah, it's similar to the presentation of the one I just presented from the last publication. Doctors. Dr. Amr.
Dr. Amr.
Thank you very much. My question is, what about if fine needle aspiration can give the diagnosis? Is it possible to start with fine needle aspiration in all the cases? And is it risky that fine needle aspiration might cause the tumor to spread?
Yes, of course. There's the possibility because one of the misdiagnosed one, they aspirate like for injections, and later they presented with a conjunctival mass because of this track. So yes, there's if it's malignant, there's a risk for that. But usually there's a trend even when we are doing now intravitreal injection with retinoblastoma. If you take a good precautions with the cryotherapy many times on the site of the injection and irrigation and lots of things, then it's safe. And when you are expecting that you are dealing, so this is very important for the residents, even for conj masses. Always think of the bad. Think that you are dealing with a malignant, so you treat it and manage it and excise it cleanly, so we don't regret that afterward. And it's the same in this. Maybe Dr. Katan can add anything on the biopsy. Of course, aspiration, it's most of the time will be not yielding. Actually, it will not, because we don't need cells. We need clumps. We need clusters to see the cords, and like the one I present. Cells, it's not like an retinoblastoma. I can diagnose it from cells, or like melanoma. It has to have this special histopathological features, so I can diagnose it.
Yeah, but it's the concern of the parents, because once they get convinced that this is really malignant, it might affect the life of the child, then they may get convinced to enucleate. But if to offer enucleation based on that this might be malignant, it might affect, then they might look for other options.
I totally agree with you, but my point is about the way how do you take this sample. FNA might not be the good option. Maybe biopsy is better. I mean, to get a big chunk of a good chunk of the tissue. Cells will not help. Maybe Dr. Katan.
And you are less likely to be able to distinguish between the malignant and the benign only based on a biopsy, or even like a small specimen, because the criteria for malignant medullobethelioma is tumor behavior, areas of necrosis, finding mitotic figures, and you might not be lucky enough to see this in a small biopsy. So you don't have really the very high pleomorphism, and atypical cells that will look astonishing to you and convincing to say that this is malignant. It's very difficult.
Even in a whole sample, it's difficult.
Yeah, it's not easy.
Yeah, I know, but the point is that what is convincing to the family.
Usually those cases presented with poor vision, light perception, or even no light perception. So with the possibilities of malignancy, probably most of them will be convinced to get rid of this eye and know what's going on rather than to keep it. We did not face a patient that we need to, when it's smaller, probably in other serious, they can do iridectomy and rather than inoculation.